a particular topic of asthma, personalized medicine of asthma. As you know, that's personalized medicine in general in any medical disease is the future, and actually a trend in the future that people start to practice personalized medicine based on patient case by case. So there is no patient who is mimicking other patients. So every patient has unique profile and unique characteristics. You need to evaluate your patient based on this one. So if you look at the definition of asthma, is basically this from Gina is the first word is heterogeneous. So asthma is no longer a disease, it's a syndrome, it's a very complex chronic airway inflammations and over-reversible airflow limitations. So the asthma is very complex syndromes, heterogeneous. So there is patients that are mimicking each other. So every patient is different from other patient, in spite of being labeled with the same diagnosis. So however, it's a chronic airway inflammation, but in practice, it's very rarely we measure inflammation as a biomarker. So most of patient asthma or asthma with patient with asthma, when they see in the practice, either in family medicine or in pulmonary clinic, and they have mild to moderate asthma, we don't measure the inflammatory markers. So most of them based on assessment of the history and physical examinations and maybe lung functions, and then we decide which category of the patient is labeled to be. So inflammation, generally speaking, is not measured in routine practice in a patient with asthma. However, there has been a shift to defining the paradigm for asthma from single disease to complex clinical heterogeneity. So we are not dealing with a single entity. We are dealing with heterogeneous, very complex syndrome. So severe asthma, on the other hand, which represent around maybe 5 to 10% of the asthma, who a patient who is in step 4 and 5, and usually they're not improved with the step 4 and 5 medication on inhalers, or they are controlled in spite looking for any other comorbidities or other cofactors. This is called modifiable risk factors. So the patient who has had good adherence, compliance is good technique, correct diagnosis, no significant comorbidities, no inflammatory factors, and still they have uncontrolled asthma. This is called severe asthma in step 4 and step 5, or difficult to treat asthma. How common? Severe asthma, about 3.7% of severe asthma, they have severe asthma. And one out of 4 patients of asthma in general, they are in step 4 and step 5 treatment based on the GINA and GINA guidelines. What is personalized treatment, or what's precision treatment? Is individualized treatment based on patient assessment. So you take the right patient with the right drug at the right time. So that particular drug is work for that patient, may not necessarily work with other patients. So this patient has different profile. So you have to evaluate the patient based on this approach. So this is a very important slide. This is looking for inflammations or pathophysiology of asthma. So if you basically, this is where you define the inflammation, 2 types, type 2 inflammations and non-type 2 inflammations. So like allergen exposures, the first thing, which is going to stimulate the dendritic cells. This is dendritic cells stimulating the T helper or T type 2 lymphocyte. Type 2 is going to reducing 3 important essential biomarkers for pathophysiology of asthma, IL-5, 4, and 13. IL-5, the main job or function of the IL-5 basically is the production or activation of eosinophilia from the bone marrow and eosinophilic maturations and proliferations and migration to the airways and deposition in the wall of the airways. While IL-4 work through B cell class switching and EIG productions and basophilic production. IG is called IG mediated asthma, while IL-13 is basically go to the wall and the smooth muscles, basement membrane thickening, global cell hyperplasia and mucus productions, and smooth muscle contractibility. So you have 3 important IL interleukins, 5 and 4 and 13, and it's called type 2 inflammation. So there's a bulk of maybe 60% of patients with asthma, they have type 2 inflammations mediated through the lymphocytes. And so identification of the triple traits is traits means is either phenotyping or endotyping or biomarker. Phenotyping means the clinical characteristics or clinical profile of the patients. Endotyping is mechanism of the or pathophysiology or mechanism of the disease, how it's happened. And biomarker is a reflection of the mechanism of the disease, which is underlying disease mechanism biomarker like interleukin and other inflammatory markers. So phenotype is basically observable clinical characteristic of the disease. Endotype is biological marker of the disease, and basically that's why we need to switching now. We're approaching the patients, especially severe asthma, from simple clinical assessment to the more in-depth evaluation based on the phenotyping and endotyping on your patient based on inflammatory markers. So it's multiple phenotypic endotyping based on in molecular analysis and multiple phenotype and endotyping we can be distinguished on those patients with asthma. So basically, this is a very complex. You see, it's how it's complex. The pathophysiology of asthma is very, very complex. It's not simple as I show you on the initial graph. This is just to make it simplified. But actually, there's a many biomarkers, inflammatory biomarker play a role in the pathophysiology of asthma and very, very complicated mechanisms. And asthma phenotyping, which is clinical characteristic of the patient with asthma, basically there is many phenotyping or profiling of the patient with asthma, but the most important, the most common profiling measurable characteristic of the patient with asthma is the age, gender, age of onset, comorbidities, allergic features, airway obstructions, and irritabilities, obesity, and smoking. Asthma cluster analysis. This is one way to analyze asthma or classify asthma based on the cluster analysis. This is one study done on more than 700 patients. They classify patients based on clusters. They classify them in five clusters. Cluster 1 is early onset of asthma, mild asthma, no normal lung functions, minimal health utilizations. And cluster 2, basically the same patient, but they are in step 2 or more than one inhalers, or more than like ICS and LABA. And cluster 3 patient, older, obese woman with late onset non-atopic asthma, and they start to have mild reduction on lung functions and frequent oral corticosteroid use and managing observations. While cluster 4, basically those patients has more, usually adult patients, more severe airway obstructions. They have abnormal lung function. They have reduction in FEV1, usually around 57% predicted, but they have reversibilities. When they go from bronchodilator, they go back to normal lung functions. And cluster 5 is the fixed airflow obstructions, irreversible or partially reversible FEV1. So FEV1 is still going below 80% post bronchodilators. However, this cluster in practice, there is a lot of overlap together. So we cannot label a patient to have this cluster 1 to 5 because there's most of these patients has overlap. So now shifting from the cluster to phenotyping the patient to important big classifications of patients with asthma, either type 2 inflammation, which is eosinophilic mediated, as I told you, which is type 2 means a T lymphocyte, type 2 T lymphocytes through eosinophilic production, interleukin 5, 4, and 13, and non-type 2 inflammation with either neutrophilic asthma, pussy granulocytic asthma, and mixed cellularity asthma. I'm going to talk about one by one about this type of a profile. Eosinophilic asthma. What is eosinophilic asthma? Is the most common type of the asthma is eosinophilic predominant asthma or mediated through eosinophilic productions. 40 to 70% of total asthma patients. And actually, to diagnose eosinophilic asthma, you need to have more than 2% of sputum eosinophilia. And if you ask for sputum productions and check the cellularity and the cell count differential, and the sputum should be more than 2% in sputum to diagnose asthma. And if you measure FeNO is more than 20, and serum eosinophilia more than 150. So this requirement to diagnose the label patient to have an eosinophilic asthma should have sputum more than 2% sputum eosinophilia, FeNO more than 20, eosinophilia and serum more than 150. And as I told you, this is mediated through the 3 important and essential interleukin in the type 2 inflammations 4, 5, and 13. And there are 2 types, early onset and late onset. Early onset, usually childhood onset, and usually atopic mediated. And late onset is adulthood, usually infection and by irritant or infectious stimulating, and usually different interleukins, which is interleukin 25, 33, TSLP, and others interleukin. While neutrophilic asthma, this is other entity of asthma, actually is basically mediated through neutrophils, not eosinophilia. Okay, so you have neutrophilia predominant more than 61% in the sputum. So if you induce a sputum for those patients, you find more than 61% of the cells in the sputum, more than 60%, and they represent around 5 to 20% of the patients. So not common comparing with neutrophilic asthma. So around 22% of the patients they have neutrophilic asthma. And interestingly, that blood neutrophilia does not correlate with airway neutrophilia. So if you measure serum neutrophil level, it doesn't correlate with the sputum neutrophil count. So you may have normal neutrophil, but they have very high or elevated level of neutrophil in the sputum. And usually they have very severe asthma, uncontrolled, difficult to treat, low lung functions, and they have frequent admission exacerbation in ER visits. So this is one of the most difficult asthma to manage and to see. And usually they are not responder to oral corticosteroid or partial responder, so very difficult to treat. Don't respond to or poorly respond to ICS. And the treatment of those patients usually either we don't use oral long-term, oral corticosteroid or inhaled corticosteroid or even LABA or other medications. But usually you can use macrolides for treatment of metabolic asthma or LAMA, long-acting muscarinic or like anticholinergic inhalers. So treatment of choice for metabolic asthma is not inhaled corticosteroids as a standard of like eosinophilic asthma, usually macrolide or LAMA. While PUSI granulocytic phenotyping, basically those patients, they have neutrophil level less than 61% and eosinophilic level in the sputum less than 2%. So you have low eosinophilia in the sputum, more than 2%. You have low neutrophilic in the sputum, less than 61%. This is called PUSI. PUSI means little. So this is represent around 17 to 48% of population of asthma. They have PUSI, granulocytic asthma or phenotyping. And usually they have, if you measure pheno, it's low, less than 25 or 20%. And they have very high level of the serum periostin. And treatment for those patients, PUSI granulocytic asthma, usually is not inhaled corticosteroid, not LABA, not leukotriene inhibitor, usually bronchial thermoplasty, probably the standard, the first line of treatment for those patients. And sometimes you may add for them LAMA, okay? And those patients, PUSI granulocytic phenotyping of asthma, usually evidence that airway epithelial cells, smooth muscle cells, and nerves can orchestrate airway inflammations. So basically the parasympathetic, sympathetic, moderated type of asthma. This is why the bronchial thermoplasty has a role on treatment of the PUSI granulocytic phenotyping. The other phenotyping of asthma is aspirin or NSAID exacerbating respiratory disease, usually male predominant. Around 2.5% of the patients with asthma, they have aspirin or NSAID exacerbating asthma. Around 15% of severe asthma, they have aspirin exacerbators or NSAID. Usually male predominant, third, fourth decade of life, and they have high level of the CYSLT leukotriene, high level. So the treatment of choice for those patients usually is leukotriene modifier or inhibitors. So LTR treatment is standard treatment for the patient with aspirin-induced asthma. Avoidance measure is standard of care for sure. And anti-IL-5, it may have a role in severe refractory cases of patients with aspirin-induced respiratory disease. Usually they have chronic rhinosinusitis, nasal polyposis, and acute respiratory reactions following ingestions of aspirin. And so you have the triad of chronic rhinosinusitis, nasal polyposis, asthma exacerbating with exposure to NSAID and aspirin. There is many other phenotyping of asthma. I'm not going to go in detail about this type of phenotyping because it's very complex, but obese asthma is a unique entity. It has special characteristic of asthma. Asthma in elderly is also a unique entity. Around 10% of asthma can be starting at an elderly age, above the age of 60. So asthma is not only childhood disease or middle-aged disease. It can happen at any age, but if it's elderly, it's called asthma elderly is around 10% of the patients. You have airway remodeling, which or persistent airway obstruction or fixed air obstructions, or like COPD-like pathophysiology or pictures. And you have a mixed inflammatory phenotyping, which you have a feature of both high eosinophilia and high neutrophil. So neutrophil count is high, eosinophilia is high, so you have mixed inflammatory phenotyping. And you have the other typing exercise-induced bronchoconstrictions. Maybe it's not asthma, pure asthma, it's just bronchoconstrictions when the patient has some exercising exposure. So exercising-induced bronchoconstrictions. So how to treat those patients? Biological treatment basically is a target-specific treatment. So you target specific interleukin based on the most predominant interleukin play a role in the pathophysiology of that particular type of asthma. So it's basically, that's why personalized medicine or precision medicines. So targeting treatment for type 2 pathway. So if you look at the marketing biological agents approved by in the routine practice nowadays worldwide, we have 1, 2, 3, 4, 5 type of the biological agent available in the markets. We have anti-IG monoclonal antibodies, omalizumab. It's the oldest one. I think it's there for more than 20 years now in the market. And you have also the anti-IL-5, so IL-5 monoclonal antibodies, nivolumab and rizulumab as well. So they have two biological agents targeting IL-5. And you have IL-5 receptors blocker or antibodies. It's called benralizumab, also is available in the market. And you have IL-13, IL-14, IL-4R receptors, DOBI. It's which work in both two interleukins, so 13 and 4, and it's also widely used in many patients with severe asthma. And recently we have anti-TSLP, tislelizumab. Tislelizumab is not available in the Gulf region as far as I know, but I think it's coming soon. So these are 5 commonly used biological agent treatment for severe asthma based on type 2 inflammations. If you look in the literature, there is many tens of names of different biological agents. And most of these failed in clinical trials or has safety issues, but is not becoming approved for treatment of asthma. These are 5 important biological agents approved for treatment of asthma. Which one you choose? I think Dr. Baram is going to talk about this in the next presentations, but it's very debatable. This is my last slide, but generally speaking, that the message I'm going to give you from here is basically is asthma is very complex syndrome or disease. It's not longer a single disease. It's a very complex, and asthma is heterogeneous. It's not homogeneous. There is no asthma patient who's mimicking other asthma patients. So each patient has unique profile, phenotyping, endotyping. You have to have a full assessment for each patient based on his phenotyping, biological and biomarkers. Based on different, asthma has different pathophysiology, type 2 inflammation, non-type 2 inflammations, different endotypes or clinical profiles. And patients usually respond differently to different treatments. So what is good for that patient is not necessarily to be a good or going to work for other patients. So patient different responders, and this is called personalized approach. So take patient by patient based on your assessment. So in severe asthma, generally that's why we're dealing in our clinical practice. But if you look in family medicine level, you see most of these patients mild asthma, and it's just take them on one disease and one single entity. But in severe asthma, you have to evaluate patient by patient. So you have there is many limitations basically in the future. We don't have in routine practice. We don't have a sputum cell count in the hospitals, in most of the hospitals. So we cannot diagnose. Very difficult to diagnose neutrophilic asthma, for example, because of many factors not available in our routine practice. We cannot measure the serum biomarker level in the serum, for example, to see this is what type of inflammation is 5 or 4 or 13. So personal medicine. So if you see a patient with asthma, the first thing is come from family medicine clinic to refer to your clinic. The first thing to do is this asthma or not? Before this is ABC. Go back to basic. Okay, so don't jump to biological treatment before. Please confirm it as a pulmonologist. Check. Please be sure that this is asthma. Real asthma is not something else, because asthma can mimic many other differential diagnoses. So confirm diagnosis, and before label the patient to have a severe asthma or uncontrolled asthma, you have to address very important basic modifiable risk factors. You have to check the patient education about asthma, adherence because the most common reason for uncontrolled asthma is adherence. Okay, and it's very simple. By talking to the patient, simple session of education, you can solve the patient's problems before jumping to very expensive biological treatment. Adherence, check the technique. You have to have asthma educator with you or pharmacist in the clinic with you. Check if there is any comorbidity of the patient. If the patient has a chronic rhinosinusitis, nasal polyposis, reflux, obesity, sleep apnea, and many other comorbidities, you have to treat them. And check if there is any environmental triggering factor to have to avoid the patient before. So if the patient has no problem with the environment, no comorbidities, good technique, good adherence, good asthma medications, asthma is confirmed, then you have to assess your patient is a mild, moderate, or control. If it's usually mild to moderate, you have to follow the step up and down approach therapy based on the GINA guidelines from step 1 to step 4. So up and down depends on assessment every 3 to 6 months. And if it's severe asthma, you have to phenotype them or endotype them. Okay, so endotyping and phenotyping based on severe asthma. Phenotyping is type 2 inflammations or non-type 2 inflammations. Type 2 inflammation treatment is usually anti-interleukin 4, 5, and 13, and non-type 2 inflammation is not inhaled corticosteroid, is basically different medical treatment approach treatment, usually either macrolide, depending on type of the asthma, the intraphilic asthma, pussy, granulocytic, or mixed inflammatory, macrolide or thrombo or bronchial thermoplasty or anticholinergic treatment. Thank you very much.
Thank you, Dr. Mohammad, for this wonderful lecture. And you summarized everything about the type of asthma and the phenotypes and the treatments. And